into the first slide. So, fundamentals of nursing, this is our final exam review. So this is our first review slide. Now remember, anything after starting with chapter 14 is testable. Okay, chapter 14 to the end of our fundamentals, any chapters in there that we covered are testable materials. Now this presentation is just starting with review at chapter 24. So what I've tried to do is focus on those highly tested chapters, those chapters of most significance on your final exam to focus on, okay? So we're starting at chapter 24, but your studies and review should happen starting with chapter 14. So heavily tested chapters are here for our discussion. So the first one, what lab do we use to measure the effectiveness of Coumadin? It's also known as warfarin. Oops, I've already ruined it. Hold on one second.
Heather.
All right, I got it. I think. All right, we up?
Yes. Are you looking at the chat box? No, huh?
Let me see. Jasmine. I can see now. Oh, I can see now. I think I'm with you. I think I'm with you guys. So the big thing for Coumadin and warfarin, the big lab is the INR. The INR is the big lab for Coumadin and warfarin. Now, when we talk PTT and PT, so those big ones go for heparin. Those are also bleeding labs. They're bleeding labs. Those are important labs for other bleeding medications. But the gold standard, #1 lab, if I asked any nurse and I walked out to the floor and I said, hey, you've got a Coumadin patient, which lab do you want? They're going to say the INR. So the INR, that is our #1 most important Coumadin lab, the INR. So that's the first one. Now, in the next slide, we do have a flashback that will show you that information on that slide. So INR is our #1 Coumadin or warfarin monitoring lab. Now, the other ones, you guys had some answers of PT, PTT. Those are good bleeding labs as well, but our #1 for Coumadin is INR. Our next point here on this slide is, how do you instruct the patient to complete a midstream urine collection? So how do we do that? Go ahead and chat. I'm watching Jasmine. I'm all over it, girl. How do we tell them to do a midstream urine collection? Pee then catch, right? It's not. Jasmine's like, I can tell you that. It's easy. Pee then catch. It's midstream, right? So start your stream, or as Jasmine Jones would say, pee then catch. Yeah, midstream. So you need to start your stream, and then you need to start collecting. Now, do they need to clean themselves before? Yes. Men and women? Yes. Now, here's where men get confused. So I used to instruct patients on collecting a midstream urine collection, and I would give men the little towelette that cleans, and they'd say, this is for women. And I was like, no, this is so any bacteria on you doesn't get in the cup and confuse the sample, sir. You know, so yes, it is for men and women. Everybody has different bacteria resting on their skin. We don't want any of that bacteria getting into the sample cup and confusing what's in their actual urine versus what was on the outside of their genitalia. So everybody needs, yes, sir, clean yourself, please do it. And then I find the little swab just not even opened in the trash can, and I'm like, right? So different things are going to show up in that urine specimen that aren't actually in the patient's urine. So everybody needs to clean first, and then they'll start their stream. They'll start to urinate, and then they will collect, and that's what makes it a midstream urine collection. So urinate a little bit and then collect. The next one, what do you need to check before giving the patient anything by mouth after procedure that has a sedative? What do you need to check? The swallow, okay? Remember, airway is always #1. Nothing is more important than airway. Do they have their gag reflex? Okay. Are they safe to swallow? So check their gag reflex and make sure that they are safe to flower. So safe to swallow. So you're going to check their gag reflex. This we've talked about a couple of times. Remember, if the doctor says NPO, you could check their gag reflex all day. You're not feeding them anyways. So you need to make sure that you have an order to give liquids and that you check their gag reflex. So don't just assume, oh, their gag reflex is intact. Always make sure that you're checking the patient's diet as well to ensure that they are ready to eat or drink per the provider's order and then also per your assessment. So you're going to check the gag reflex. The next one, what is the correct position for a patient after a liver biopsy? On their right side. So I have in my notes referred to table 24-5. So make sure that you know the positioning there. I would check that out as well. And then how do we perform a wound culture? How do we do that? Like, are you looking for the prettiest part of the wound? Like you're looking for like the non-yucky part? Like you're like, okay, wherever it doesn't look messy is where I'm going. What part of the wound are you looking for? You're looking for the gross stuff. You look for the yuckiest, right? You look for what can get a sample. Now, would you want to jam it into something that's not going to give any fluid? No, you want to look for something that you can really sample. Also, do you jam it in and are you rough when obtaining it, trying to get rid of all the tissue and messing it up? No, so you need to you're going to rotate the swab gently in the wound bed, okay? Now, what kind of gloves would it require? What kind of gloves? Like no gloves, just going blind on this one. So sterile gloves. Sterile gloves, remember, if they've got a wound, you're exposing them to anything. So we want to be as clean as possible. So we want to use sterile gloves when obtaining. We want to rotate the swab gently in the wound bed. And when we place that swab in the culture tube, what do we want to be careful to do? So we've done it. We did our sterile gloves. We picked kind of a gross area that had material to actually be cultured. We've gently done it. Now we're ready to put that in the specimen tube. So don't touch the sides. We don't want to touch the sides. So key fact here, we do not want to touch the sides because what's going to happen is you're putting it down into a medium to preserve it to be analyzed. If you bump the sides 15, 16 times on the way down, bump, 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 once you get to the bottom, you might not have much left, okay? It's been very interrupted. So be careful not to touch the sides of the tube. So key fact there. Lastly, how do we instruct a patient to complete a 24-hour urine collection? So 24 hours, this is a 24-hour test. There's also 12-hour tests. What do they do with their first urine? Do they get rid of it? Ooh, Josefina, that's right, girlfriend. They empty their bladder first. Now, does that go into the container? Pee and then throw away the first one, right? Then the clock starts. So they're going to urinate. They're going to get rid of that first one, and then the clock starts. Now, can they just leave that urine jug anywhere, like out on the table? You know, they got it in their backpack. Who knows? People do weird stuff. Don't even be surprised. No, where do they need to keep it? Where do they need to keep it? It needs to be on ice or in a fridge, right? So it needs to be, now sometimes people are like, well, I don't have a fridge. I'm like, well, if they don't keep it on ice or cool or refrigerated, that sample is going to be, it's going to be bad. They're not going to be able to process it. So they're just going to end up having to redo it. So I usually tell patients, if you do it right the first time, you won't have to redo it. So make sure that you protect your sample and you keep it refrigerated or on ice. So it needs to be kept cold. Now, what happens with the last pee? Do we toss that one? So we keep the last pee, or the last urine, shall I say. You guys got me on pee now because I see pee so many times in the chat box. So we keep the last urine. So we toss the first one. We keep it preserved. We keep it on ice or refrigerated, and we include the last urine into the sample. So that's our 24-hour urine collection. All right, everybody. So the next couple of slides I'm going to flip through rather quickly. I'm going to toggle back over to my presentation, and I'm going to go through the next slides a little quickly. So on this one, the INR is The prothrombin time is reported in INR numbers. So we want the INR number, We want how that prothrombin time is reported. And in this case, we want the reported INR number. Here, urinalysis, this is a midstream collection. We talked about this. Urinalysis continued. So here's some information on that 24-hour urine specimen. And now we're going to go into our next very short chapter review. So the first one, deficiency in vitamin D also puts the patient at risk for what other deficiency? So something I felt like that we've mentioned a couple of times, maybe not in great detail, but I do feel like we've mentioned it. So what other deficiency? Calcium. So I already see the answer here. So vitamin D deficiency also puts the patient at risk for calcium deficiency because of the patient's inability to absorb calcium. So vitamin D and calcium go hand in hand. Deficiency in vitamin D, we expect to see a deficiency in calcium as well. Very good. Now on this slide, I've put the information that students need to review respiratory alkalosis, respiratory acidosis, metabolic alkalosis, and metabolic acidosis independently. Now we did a little review on this many weeks ago at this point. We watched a short video and go back to your notes on that section. There's one box in the book that I pointed you towards, and it said, if the patient had this, what we would most expect. Now, this final doesn't have a ton on this, but there are a few questions. And because it is a confusing subject matter and kind of right when you learn it, you might be like, oh, I think I got it. And then you put it out of your head. It's not something that usually comes back rather easily. So I want you to spend just a couple of minutes looking over that. It's not a super heavily tested concept, but it's probably worth your time. Spend a couple of minutes and just refer to those conditions that what you would expect. So in the essence of time, I'm not going to re-lecture you on that, but you should have some notes on when we did it. I also pointed you to a pretty quick video. I know that video was useful the day that we watched it. This isn't the last time. I mean, I'm still going to be here for you guys. So if there's a concept that you really can't get after this review, then you can always reach out to me and I will assist you guys with it. Okay, so I'm still your instructor. Yes, so exactly right. So in the beginning, Valerie said Sadia's review was helpful as well. Like totally. That's why if you can get it in one class, it will help you in another. If you get it a little bit in my class and you get it more in Sadia's class, then it reinforces it. Then you're going to move on to your next module and you're going to hear it from somebody else and it's going to help even more. So remember, it all goes hand in hand. And that's why I tell you guys, if you're only being a little successful, but you're putting in the work, eventually getting it from a lot of different places, it's going to end up making sense if you just keep going for it. So Sadia is wonderful. Sadia, so it probably further elaborated on what I talked about, and next mod you'll get it again. So do review that briefly. There's just a few questions on it. So I'm going to flip back to my slides. All right, so you're going to review that independently. So just a really quick slide on calcium. Remember that goes hand in hand in vitamin D, with vitamin D, excuse me. So now we're on chapter 26 review. So chapter 26. So how much should we limit cholesterol intake to each day? How much? Be specific. 300. Josefina, great job. I knew you were like 10 short. Yep, you guys are exactly right. 300. Yes, I could tell. I was like, I know they're missing the 0. Yes, so the American Heart Association, or the AHA, suggests that we limit our intake to 300 milligrams per day. Very good. Now, what are some risks associated with a vegan diet? What are some risks? Like, I'm not trying to rag on the vegan diet. There's definitely some advantages as well, but iron deficiency is a major risk. We'll see the vegan diet. So some other things that are for vegan diets, they're at risk for vitamin B6, vitamin B12, iron, zinc, riboflavin, and vitamin D. So there's several things. For you guys, I want you to put an asterisk on the fact that they're at risk for iron deficiency, okay? So nothing against those other things. Yes, they are at risk for them as well, but iron deficiency is the big one we're going to be focusing on. So iron deficiency. And then lastly on this slide, how can a type 2 diabetic maintain a more consistent blood sugar? How can a type 2 diabetic maintain a more consistent blood sugar? So definitely the type of carbs they eat. So imagine complex carbs. Oh, very good. So the type of carbs they eat. Now, okay, so think about it like this. If I have a big piece of cherry pie and ice cream, right? Not very good carbs, right? So just high sugar, not much content, simple carbs. Now, if I switch those carbs that I used instead of eating the cherry pie and ice cream, and I switched it on something like a whole grain bread or a brown rice or a complex carb like that, the complex carb is going to regulate that person's blood sugar for much longer. So it's not much different for a diabetic than us, right? If we have a very sugary something, our sugar spikes and then plummets rather quickly. Now, a diabetic who wants their sugars to maintain a very consistent level, if they're picking those like just sugary, you know, oh, I'm going to have a Pepsi instead of eating any good carbs, their sugar is going to spike and then drop rapidly. So it's going to lead to heavy fluctuations. So what we want to do is we want to educate them on being sure to eat complex carbs, things like pasta, cereal, rice, that are going to regulate their sugars instead of giving them those extreme highs and lows that those more sugar-based things like having a soda instead or just a dessert. So we want to focus on the complex carbs. Very good, guys. So just take me 1 second to get over to our presentation. Now, a couple flashbacks here. So the vegan diet here, it's deficient in these things. I've highlighted iron deficiency as a special thing of note, but all of these vegan is potentially going to be deficient in. And now we're moving into chapter 28. Chapter 28 is a huge chapter, okay, guys? This is a very important chapter. So chapter 28 is very important for you guys to know. It's got a lot of points here on a review slide. So let's start at the top one. How do you perform the Heimlich maneuver? How do you perform the Heimlich maneuver? So do we want to aim for the xiphoid process? Do you know where your xiphoid process is? So the xiphoid process is the little bone at the bottom of your sternum. So if you aim for that and you put a lot of pressure there, guess what's going to happen to the xiphoid process? It's a very narrow, skinny bone. So that's going to pop right off. It's going to break it. Literally, Wendy, you nailed it. It will break. So yes, that will break rather easily. If you look at how it's composed, it's very skinny, it's very narrow, and it's going to pop off, and it's going to be able to travel around and possibly puncture something. So we want to be careful to avoid the xiphoid process. So what you want to do is position your fist halfway between the xiphoid process and the umbilicus. So Valerie, you nailed it. So awesome. And then Kevin, awesome ideas in there. You guys, great job. For those of you chatting, and for those of you I know that are also just taking notes, great job, guys. So you want to position your fist halfway between the xiphoid process and the umbilicus. So that's for the Heimlich maneuver. Now, what if the person was pregnant or you couldn't get your arms around them? You still go there? You're like, well, my arms don't fit. I'll just do the best I can. So how do we do that? You just say, sorry, doesn't fit. Do the chest, right? Do the chest. You keep going up until you can get your arms around them. So you aim for the mid-chest. Once again, we should not be on the xiphoid process, but we do the chest instead. Very good. So there are going to be some patients, whether they're pregnant or not, that you can't get your arms around them to position. And at that point, we go to the chest level. Very good, guys. So the next part on the slide is, what is postural drainage and when is the best time to perform it? So this is a little bit longer question. So take a moment and see if you can chat out or consider postural drainage. What is it and when is the best time to perform it? Take a moment to chat and then we'll get going. Yeah, so I already see some good thoughts in there. So essentially, different positions or postures or positions drain different segments of the lungs. So it's the ability to position our patient to facilitate drainage of of the lungs is what postural drainage is. Now, think about it this way. When is the best time to get all the junk up? When's the best time? Like if you have junk in your chest, right? You have a cold, whatever you have, and you need to get all that stuff out. Oh, in the morning. So when you think about it like that, you're like, okay, my patient's got junk in their lungs. When's the best time for me to get that junk out? Definitely in the morning, right? So in the morning is when they've been laying flat usually all night. All that stuff has been accumulating. They haven't been awake, and it's all sitting in there kind of primed to get out. So in the morning is usually when is the best time for our patient to get all of that junk out. So postural drainage is best performed in the morning prior to eating because secretions accumulate while the patient is asleep. So same thing, just like when you're sick and you're laying flat and you're like, okay, I went to bed feeling pretty good, and in the morning I'm a zombie again because all that junk accumulated all night, and in the morning it is fresh and it has been sitting all night. So that is the best time for postural drainage is the morning. Now remember, different positions drain different areas of the lungs. Now you don't need to know specific positions, just know definitely when is the best time. So the morning is an excellent time. All right, so why do we humidify oxygen? Why do we add a humidifier to oxygen? Ooh, Sean. Sean, man, it's nice to hear from you. Awesome thought in there. So it helps moisten it, right? So oxygen is very drying. Oxygen dries out our mucous membranes. Very true. So oxygen dries out our mucous membranes. And if somebody's on oxygen long-term, it really dries them out. It dries out the respiratory tract. So we want to keep the oxygen moist. Now, the main patients that we want this moistness for are patients with sinus problems, okay? Sinus problem patients need humidity. I don't care if it's short-term or long-term. They're already dry. If you dry them out further, it's going to be bad. So our patients with sinus problems is going to further irritate and dry them out. So we want to make sure to use humidity for our sinus problem patients. Now, another patient that we'd want to consider is our patient on a lot of oxygen. So when you flow, say, 5 liters into their nose, and that is a very high rate of oxygen, it's going to dry them out even faster. So primarily it's sinus patients with sensitive sinuses to further dry them out. And it's also our patients on high flow of oxygen. So that high flow of oxygen, high levels and high rates is going to dry them out even faster. So those are our patients. And we do that to help moisten and make sure that we're maintaining moist mucous membranes for our patients. Very good job, guys. And how do we manage the flow of oxygen for a COPD patient? COPD. Oh, you guys came locked and loaded for that one. Okay, I like it. So let me ask you this. What stimulates, so what is COPD? COPD. Somebody, I'll give you guys a second to chat. COPD. What is COPD? Chronic pulmonary. So chronic obstructive pulmonary disease itself. Don't add a question mark. You're like, maybe. Yeah, girl, you crushed it itself. Awesome. Awesome job, Valerie. I'm really proud of you guys. Okay, way to go. So chronic obstructive pulmonary disease. Now, for these patients, they run off what's called a hypoxic drive. Super interesting here. So hypoxic drive. Low levels of oxygen stimulate them to breathe, okay? So they get the incentive to breathe from lower oxygen levels. They run off of a hypoxic drive. Now, most people run off of higher levels of CO2 because when you have high levels of CO2, it tells you you need to breathe, right? For these people, they already have continuously high levels of CO2. So they already have chronically high levels of CO2, so that high level of CO2 does not initiate them breathing. what initiates them to breathe is that hypoxic drive, the fact that they are short on oxygen. So if we give somebody who needs to be short on oxygen to remember to breathe, lots and lots of oxygen, we are going to ruin their hypoxic drive. So we need them to have that hypoxic drive to stimulate them taking breaths. So for these patients, if we flow the oxygen too high and we turn it up to 5 or 6, you're like, their SATs are only 90%. I'm going to turn it up to 5 or 6. Their SAT is going to go from 90% to like 85%. Their O2 saturation is going to go down because we've taken away their hypoxic drive. Remember, these people are always used to having high carbon dioxide level. They live on high carbon dioxide levels. So that's not going to be enough to stimulate them. They need low levels of oxygen to stimulate that. So that's why we keep their oxygen levels lower. 2 to 3 is the max. We don't want to go any higher than that. So 2 to 3 is the max. Any more, you're going to have the response that you don't want. Their SATs are going to drop further, and their breathing is going to become worse. So low levels of oxygen for these people. Now, smokers, common disease, totally, Jasmine. COPD, very common in smokers. So definitely, definitely common in smokers. Oh, sorry, my voice is already kind of trying to quit on us. Okay, next question. How do you know if your patient, students need to independently review the different types of oxygen masks? So I wouldn't spend eternity. I'd spend a good 5 or 10 minutes looking over the different kinds of oxygen masks. There are a couple of questions on oxygen masks. So I need you to look at them, look at their flow rate, and look at what situations they'd be used in. So you're going to do that independently, okay, guys? The next thing, how do we know if our patient needs suctioning? If you just look at them, you're like, I don't know, maybe needs suctioning. So trouble breathing is definitely definitely something you're going to look at them like, oh, they got trouble breathing. And then the next thing you're going to do is you're going to listen to their lungs. You're going to auscultate the patient's breath sounds. Because sometimes does somebody sound gunky, but you listen to their lungs and it's more upper, definitely. So nothing wrong with listening to your patient. They sound junky, right? You're like, oh, they sound junky, okay? But then you listen to their lungs. So totally, we want to assess our patients, assess them visually and see how they're doing. But the best thing to do is auscultate the patient's breath sounds, okay? This will help assess for retained secretions to determine if your patient needs suctioning. And then what would we need to set the suction machine between? So kind of tricky. What would we need to set the suction machine to? Interesting. 80 to 120. So I would make sure that you, Jasmine, I love it. Okay, millimeters of mercury. Yes. So the answer is you need to auscultate your patient's breath sounds. Of course, you're always visually assessing them. If you feel like they probably have some junk, you're going to take a listen to their breath sounds. And then you're going to determine that they need suctioning. And when you get ready to do the actual suctioning, you're going to set the machine between 80 and 120 millimeters of mercury. Very good, guys. Now the last one, how do we teach patients to use an incentive spirometer? Literally the cheapest, most non-exciting looking medical supply that there is, and one of my all-time faves. So the incentive spirometer, how do we instruct them to use it? Even if you just type a few words, I'll know that you get it. You don't have to type me. That thing really works like 100%. Yeah, so it depends on where you have it set. So it's an incentive, right? So it's an incentive spirometer. So we give them an incentive. We give them an area we want them to hit and maintain. And it's usually got a smiley face or a little bar, and that's their incentive. Like, okay, aim for that. Okay, incentive spirometer. So they want to take 10 slow, deep breaths every hour. Okay, so what they're going to do is they're going to blow out their air and they're going to take a deep breath. Once they take that deep breath, they're going to try to hold it for 3 seconds. to enhance the gas exchange. And Jasmine says do it during commercials. That's exactly how I used to instruct my patients. I've seen patients do it 10 times in a row, like they're running like a sprint. They're like, I'm done. And I'm like, no, not much gas exchange, right? Like it's better than the person who doesn't use it, totally. But do you think all 10 breaths are awesome if they do it repetitively as fast as humanly possible? No, totally not. So I used to instruct them every commercial that comes on, do 2 or 3, do them right. Next commercial, do 2 or 3, do them right. With enough commercials, they're going to get there 10 times an hour. Totally not helpful if they're rushed. As a nurse, that's how I instructed them. Because if you stood there while they did 10, they would be exhausted. You would have spent 10 minutes watching them do it, and it wouldn't be their best breaths. So that's kind of the art of nursing, right? The science is take 10 slow, deep breaths every hour, hold each breath for 3 seconds to enhance gas exchange. In reality, you're going to find your different art. For me, it's much like Jasmine said, is I instruct them to do it each and every commercial just a few times to make sure that they're doing it well. So very good. So know the science of it, those 10 slow, deep breaths every hour, hold each breath for 3 seconds to enhance that gas exchange. And when you get out there, I think you'll probably end up doing it where you want to instruct them to do it slowly, probably over the course of commercials, because you'll notice that probably every single patient you have watches a whole bunch of TV. And it's a good reminder for them too, is you're like, hey, next commercial, you're on it. And that way they can remember. Very good, guys. Awesome. So chapter 28 is a big chapter, okay? So I want you to make sure you spend a little time there in chapter 28. So I'm going to run through those kind of flashback slides. So we're moving here. So from chapter 28, airway obstruction and respiratory arrest. So we talked about secretions and the Heimlich maneuver. Postural drainage, we talked about different positions, drain different parts of the lungs. We also mentioned that the morning is the best time before our patient eats. Oxygen administration, so here is concentrations of oxygen high. They dry out the tissue of the respiratory tract. We need to pay special attention for our patients with sinus problems because their sinuses, they already have very dry mucous membranes, and it's putting them at further risk with that oxygen flow. And then here we just see the humidifier set up. So what's going to happen is the oxygen is going to flow through it looks like sterile water in this or normal saline, and it's going to moisten it before it goes to your patient, therefore keeping their mucous membranes moist. Oxygen administration continued here. So here, the COPD patient is given 2 to 3 liters per minute, preventing respiratory arrest. Remember, these patients run off of a hypoxic drive. The low levels of oxygen stimulate them breathing, so we don't want to give them too much oxygen. Suctioning, we talked about suctioning. We have the suction pressure set between 80 and 120 on this slide. Remember, the best way to know if your patient needs a suctioning is to go ahead and take a listen to those lung sounds, okay? Listen to those lung sounds. Teaching the incentive spirometer, in here you can see that little blue, it looks like on the side, a little blue notch on the right side of the picture. That's her incentive. That's what's telling her how far she wants to try to get to. Sometimes it's a little smiley face or different things. That's giving her a goal. This person is just trying to show her how to utilize it. We talked about taking those 10 slow, deep breaths every hour and holding each breath for 3 seconds to enhance gas exchange. So now we're going to move into chapter 30. This is our next discussion slide. So chapter 30, what do different color stools mean? What do the different color stools mean? So what would a dark black stool mean? Dark black stool, what would that mean? Occult blood, the patient's bleeding, okay? Possible blood. So remember, bleeding is the most serious concern. So dark black, it's usually sticky. This is a presence of occult blood. So this is a primary concern for you. What would a pale stool mean? A pale, so it's just pale. A pale stool. Bile, absence of bile. Absence of bile, very good, guys. High fat stools. These are foul smelling and they float. So high fat stools, you'll literally see them afloat. They're very foul smelling. So do know what these different types of stools mean for your patients. Very good job, guys. The next thing is, what bowel concern would you have regarding a patient who had a barium study? So if your patient has a barium study, are they prone to diarrhea or constipation? Constipation. So a patient that has a barium study is more prone to constipation. So as a nurse, what should we be prepared to do for these patients? We know that they're going to be constipated. So we're like, okay, they're going to be constipated. What are some things that we're going to want to encourage for this patient that had a barium study that we already know? Yeah, so I like it. So fluid intake. So we always want to start with the least invasive thing, right? So we want to start slow, meaning that you don't want to come back and then say, okay, we're cleaning you out, enemas till clean, you're going to be constipated. So start slow. Things like increasing water, like, hey, you just had this barium study, you're at risk for constipation. Please make sure that you're staying hydrated. I'm going to fill up your water, things like that. I need you moving. I need you to make sure that you're staying active. I need you to perhaps a stool softener, depending, right? So all good ideas. And bowel care, KB gave the general idea of bowel care. Yeah, bowel care, totally. And enemas, Audrey said, definitely, if the constipation continues for the next couple of days, they could need an enema. So we want to start with the easy things like fluids, encourage PO, and perhaps give laxatives if necessary. So we expect these barium study patients to be prone to constipation. The next one, what are enemas until clear? Enemas until clear sounds majestic, right? It truly isn't. Enemas until clear. Oh, yes. Okay. This all sounds like fun and games until you're the nurse that's administering enemas until clear. And you'll think back to this lecture and you'll say, that's not how Heather described it. That's right. You'll think back to this moment. Okay. So enemas until clear, you're going to give them until what comes out looks clear. Okay. It doesn't have any fecal matter yet. You can't even identify it as stool anymore. Okay. You can only give up to 3. You only want to give up to 3 enemas, no more than 3 large volume enemas, because the patient is going to be at risk for possible electrolyte depletion. You don't want to dehydrate them. So in the real world, you don't remove a fecal impaction. That's kind of a controversial thing. In the real world, fecal impactions should not be removed by us. No. In the real world, we should not. Yeah, the cleanup is terrible. Jasmine, me and you are always on the same level as far as, yeah, we know this is going to be an ugly situation. Yes, we really want to be careful about electrolyte depletion for these patients, okay? So no more than 3 large volume enemas can be given because of the possible of electrolyte depletion. Yeah, CNAs all the time, so definitely. The next one, what's the function of the small intestine? So the function of the small intestine, what comes first, the small or the large intestine? Small intestine first, definitely. Okay, small intestine first, then large intestine. So what are the functions? So the small intestine processes that chyme. Okay, remember that chyme is like that semi-fluid mass that kind of gets mixed and mashed around. And it absorbs food substances into the bloodstream. So I'll repeat that. The small intestine, it processes that chyme into a more liquid state, and it absorbs food substances into the bloodstream. Anybody needed a third time? You guys all good? You guys look good. Okay, sweet. All right, then last one here. What should a stoma look like and what findings should be reported? So what color should the stoma be? Red's a good color. Pink is a good color. Moist is good. These are all good things. Pinkish red. Yeah. right? What healthy tissue looks like: pink to red, moist. It should look alive, right? Pale. Pale means no blood supply. So it should look like a healthy mucous membrane. It should look like the inside of the mouth, right? Nice and pink or red, nice and moist. Now, when the stoma is pale, this indicates that there's compromised blood flow. So it's not getting that oxygen, it's not getting that blood flow. And this needs to be reported immediately to the primary care provider. So a pale stoma is bad. Stoma should look like a nice, moist mucous membrane. Very good job, guys. So I'm going to take a moment and toggle over and get our next sets of slides. So here's our flashbacks. Abnormal stool, you guys crushed this. The occult is the upper GI bleed. Those are the black sticky stools. Hypoactive bowel, we talked constipation and that barium study, how it puts us, our patients at risk for constipation and what we can do. And here, enemas until clear. We give it until the return fluid does not have fecal matter in it. And if it's repeated, electrolytes can be dangerous. Intestines, we went over the small intestine. Ostomy, so the ostomy should be pink or red and nice and moist, and paleness is indicative of lack of oxygen supply. And now we're going into chapter 31. So a couple of review questions here. So sorry if you hear me moving some papers. So explain chronic pain versus acute. So let's start with acute pain. What's acute pain? Acute pain. Short, right? Like it's usually short in duration. It's usually associated with like an injury or a medical condition. Like I sprained my ankle. I'm in pain right now because I sprained my ankle. Or I had my gallbladder out, so I'm in pain for a short amount of time because I had my gallbladder out. Now, chronic pain is long-term. So it's months or even years, and it's associated with ongoing problems. So not like an ankle sprain, but like arthritis. Okay, I have arthritis. It's not going to be better tomorrow. It's not like my ankle. It's going to heal, and after a few weeks, no more pain. Chronic pain is long-term, and it's highly associated with things like arthritis or back problems, okay? Diabetics, they have chronic pain because of neuropathy and different things as well. Their pain is a lot of times like nerve pain, and it only typically gets worse over time. So pain, remember, it's the fifth vital sign. Acute pain is shorter, and it's usually related to an injury, a medical condition, or some sort of surgical procedure. Chronic pain, this lasts for months or even years, and it's associated with ongoing things that don't get fixed, like arthritis and really chronic bad back problems. These are things that are going to cause chronic pain. Very good, guys. Now, ice. How do we apply ice? Like as long as you want, all day long? Oh, I love how you guys are ready with these answers. Way awesome job, guys. So you need to protect the skin. So you don't put ice right on the skin. It needs to have a barrier. The barrier can be a towel or a pillowcase. I see, yeah, way to go, KB. Wrap with a towel, use a barrier. So 15 to 20 minutes, you guys have the time frame in there. Really good job, guys. So ice should be applied with a towel or other barrier between the pack and the skin, and should be left in place no more than 15 or 20 minutes. Now, don't be surprised. This happens to me all the time where my patients go, well, no one ever told me that. Are you sure? And I'm like, yeah, I'm sure, 15 to 20 minutes. 15 to 20 minutes, because sometimes you're going to be telling them something that nobody else has taken the time to tell them. And that's okay. Stick with your guns. Tell them why. Explain that that you don't want to make them so numb that they can't feel anything, and that you can only apply it 15, 20 minutes, take a break, and you'll get it back on. So don't be surprised if sometimes your patients are like, what? I wasn't told that. Do make sure that you're always working on educating them. Okay, very good job, guys. The next one, explain why medication patches like fentanyl patches are used. So why would we use a medication patch compared to, ooh, Jasmine, ooh, typing that as I was talking, girl. Rotate the site, check the skin, rotate, so dose, dang, won't be accurate at same site. So long lasting, right? So do you think if I sprain my ankle, they're gonna say, here's some patches for your pain? Like, no, definitely not, right? So different type of pain. This is going to be for more like my chronic pain patients who are expected to be in pain for longer term or chronic pain. So these are going to be our chronic pain, like KB said. We really, really, really want to monitor their respiratory status. It's not like a pain pill where I walk in, I'm looking at my patient, I'm assessing them, they're wide awake, I'm giving them a patch, and I'm basically walking away. I need to make sure I'm keeping a very close eye on their respiratory status before I give them a new patch. So I need to assess their respiratory status. Their respirations can become very shallow. If they're dealing with a fentanyl overdose, those respirations come shallow. They can become very sleepy. They can get to the point where they can't walk. They're confused. If this happens, what would you do? So your patient, you know, you put a fentanyl patch on maybe about an hour ago. You left the room. They were fine then. Take it off, right? You take it immediately off. If this happens, take it off and clean that area, okay? What else should I do? So I've taken it off, I cleaned the area, and I'm like, okay, who should I notify? Call the doctor. Because does that mean that's the right dose? Like you're like, I want to do this again tomorrow. Like, this sounds like fun. No. If you don't call the doctor, the order's going to stay the same and the patient's going to be at the same risk tomorrow. And what if your day off is tomorrow and you reported it to night shift and they don't tell day shift and no one ever tells the doctor? Then guess what's going to happen the next day? The same thing's going to happen. And this person might not make it through this time. If their respirations goes too low and someone can't, yeah, the patient could totally die. So if you notice something like this and you've removed it, you've cleaned it, the next thing you need to report it to the doctor so he can reevaluate the dose that this patient's on. Very interesting, a very good job. So we would give these patches so they can be absorbed slowly. For our chronic pain type of patients, we want to really be sure to assess their respirations. And if we feel like they're getting too much, they're reaching this overdose level, we need to remove that patch, clean their skin, and notify the doctor so that dosage can be reevaluated. Very good job. What is an epidural analgesia? An epidural analgesia. Very good. I'm seeing some good people chatting here. So epidural analgesia, this is an anesthesia that involves placing a catheter in the epidural space. So I see some of you saying the epidural space. Very good. So we're going to place a catheter in the epidural space near the base of the spine. And it's connected to like a programmable pump. So we can kind of keep an eye on this flow. Now the patient, are they going to be sedated or alert in this case? Most of the time. Now, sometimes things turn, but for the most part, these patients are meant to be alert, okay? So they should be alert. Now, the side effect, just like when we talked about fentanyl, is respiratory depression. We want to monitor these patients for hypoventilation, respiratory depression. So we want to look for hypoventilation. And of course, we cannot stand there and count the respirations. Like, okay, I'm at 14, and now I'm 16, and now I'm 18, and now there's 12, and you can't sit there all day. So a lot of times we're going to monitor this by looking at their oxygen or pulse ox numbers are going to be monitored closely to let us know how much oxygen they're getting, and we're monitoring them for the hypoventilation. Very good job, guys. I'm going to toggle back over, and we're going to flip through a few slides. All right, so chronic pain versus acute pain here. More focus on acute pain here on this slide. Focus here on chronic pain and how common conditions include arthritis and that chronic back pain for these chronic pain patients. And now we're going to go into chapter 33. Chapter 33 is another big chapter, okay, guys? So I'm going to come back over so I can see you guys. Okay, so chapter 33, oh, you guys are already on it. Okay, what route of administration works the fastest? IV, it does not mean it's the best, but it works the fastest. IV is the fastest route of medication administration. Very good job, guys, working ahead. Awesome, so IV is the fastest. How does a patient's liver function impact the way that we give medication? So good liver function, does that mean we can give regular doses of medication if their liver's working properly. So a good working liver, we give regular amounts of medications. What about a bad working liver? Their liver function is poor. Do we give them the same amount of medication? Negative. Do we give them more or do we give them less? Ooh, Pa, you're on it, girlfriend. We give them less. So their liver is not working. We do not want to keep their medications that they receive at the same level. We want to provide less medication for these patients. So that's why we make sure that we monitor a patient's liver function. So if the function is lower, we need smaller doses of medication because we don't want excess meds to accumulate. This would eventually lead to toxicity. So lower liver function, lower doses of medications should be used. Very good job, guys. Why is it important to give medications on time? Other than like it's important, right? Duh. Like, why is it important? It's because it's important. But what concept of concentration? So I want you to, oh, see Kevin, ooh, look at you. Oh gosh, okay, I'm proud of you guys. All right, so when I'm associating concentration here, like, of course, we need to give medications on time. So what we want, when medications are given late, the concentration level of the drug in their circulation drops, okay? So say we need to give it twice a day, 9 a.m., 9 p.m., but you're running late at 9 p.m. and you don't get to it till midnight. So that level of that medication inside of our patient could drop below the minimum effective concentration level. So we don't want the level of that medication in our patient to drop below the minimum effective concentration level. Our goal is to keep the drug's level above this minimum concentration level. So when we give medications that are quite late, we could go outside of this level, and then we have to build that back up within our patient. So we want to make sure that we're maintaining this therapeutic level or this minimum effective concentration level. Everybody with me on that? Does anybody need me to repeat? Everybody's cool? Okay, so we're going to make sure that we are keeping the drug levels above this minimum concentration level. Very good, guys. The next one, why are medications that suppress the CNS not to be mixed with alcohol? So alcohol does what to our CNS? Does it ramp it up or does it depress it? It depresses it, right? It suppresses it. So it makes our CNS go down. So alcohol does that, and some medications also do that. So if a medication does that and alcohol does that, we have like a double effect that's pulling down or depressing our CNS. So alcohol has the same effect when combined with drugs that depress the CNS. So if the medication is a central nervous system depressant, you combine that with alcohol and the combination is going to be even more powerful. So it's like lower and lower. Very good, Jasmine. Everybody has some really good thoughts there. Very nice job, guys. So alcohol with something that already depresses or suppresses our CNS, that is a double no-no. It's going to make that reaction even more powerful. The next one, how can we educate older adults to help with the fluctuations in their blood pressure? So we know that as we change positions, blood pressure fluctuates, and older adults, they're even more susceptible to these fluctuations in their blood pressure. So change position slowly. Now, to me, this is like the incentive spirometer of positions, okay? This is like super important. So change position slowly. It truly, truly does work. So any CNAs out there, do you see that this really, really works? Like, this seems like, you know, sometimes you guys don't think the basic things are very cool. You're like, yeah, change position slowly. Like, this 100% works. You need to educate them. Change positions, go from low or laying to sitting. No, old people don't listen. Jasmine, did we skip one? Thank goodness for you, Harley. Harley, we never hear from you, girl, but when we do, you're on point. Okay, I'll come back to it. Yeah, I'm going to tell you, Jasmine, you're exactly right. My father-in-law has fallen and broken his leg 4 times in the last year because of not changing position slowly. And I'm like, you need to change position slowly. He don't listen. You're right. But you know what I tell them still? You need to change position slowly. Um, so I still tell him though. But yeah, you're right. Sometimes it don't work. But if they do it, if he did it, if he listened to me, he wouldn't have a broken leg again anytime soon. I do not guarantee that though. I don't think that's going to happen. Yes, they want to be independent. They don't want nobody to tell them anything. They don't want, nope, nope, nope. All right, Harley, I'm going back for you, girl. Oh, you're right, Harley. What is the concern of taking long-term anti-inflammatories? Long-term GI bleeding. Oh yeah, renal failure is a good idea. Like long-term, it's going to affect your kidneys. That's a good thought too. I like where you're going with that, Valerie. Ulcers. So long-term anti-inflammatory therapy for things like arthritis. These medications are very hard on the GI system. So they put patients at risk. So these long-term anti-inflammatories, and think of the elderly population, right? Like heavy amounts of arthritis, large amounts of these NSAIDs. They need to be monitored for GI bleeding and anemia. GI bleeding and anemia, we need to watch for GI bleeding. Now, it's not to say some of these other thoughts are not good. These other thoughts are definitely good, but we're looking mainly for ulcers because they're harsh on the stomach, and we're looking for anemia and GI bleeding. Other thoughts here are really good, guys, but that's where I'm focusing our thoughts on. And thank you, Harley, for letting me know, keeping an eye on me. How do we know why a patient's taking a med? You're like, okay, you ask them, you're like, why are you taking this? They're like, I don't know. Don't ask your patient, they don't know. I ask them, but they usually say they don't know. When and where? When and where? So medications, how do you know? Like you're like, okay, I see something here for acid reflux. I see something here for a blood thinner. Like maybe this guy had a DVT. He's on Coumadin. Like Coumadin's not just a regular anticoagulant. Like that's a pretty hardcore one. I wonder if he had a pulmonary embolism. You have all these thoughts. You go to the medical history. The medical history, you're going to be like, you're going to look at this patient's meds. You're going to be like, wow, a fentanyl patch. They must have some chronic pain. I'm guessing it's arthritis or back pain or maybe fibromyalgia. Who knows? And you're going to look at their next med and you're like, interesting. I see this and interesting. And you're going to have all these questions. And yes, you can ask your patient. But the place where you're going to find that is you're going to scroll to the medical history and you're going to be like, yep, called it. DVT, knew it. Pulmonary embolism, called it. You're going to look at it and you're going to say fibromyalgia, called it too. Lasix and potassium, you might see congestive heart failure and you're like, yep, they've got their Lasix, they've got their potassium. And you're like, that goes with their congestive heart failure because they got too much fluid. So you're going to look at your meds. And when I taught clinicals, my students, I mean, they never knew how I did it. And I was always like, it's right here. But they were always like, how do you know that patient must have a pulmonary embolism? I'm like, because they're on Coumadin. They just don't give Coumadin to everybody. They give it to people who had big problems. Like, you know, I'm guessing he had a PE or something. They're like, oh my God, he had a PE. And I'm like, and they're like, wow. And teaching clinicals is a confidence boost because they're always like, oh my gosh, you knew it. And I'm like, yep, I knew it. So I confirm it with the medical history. I can look at their meds and kind of guess what they have. And then I confirm it with their medical history. So it's pretty cool. And eventually, now don't get me wrong, your meds in the beginning are not going to be at that level where you're just going to look at the meds and you're going to spout out everything. But over time, your medication skills and learning will definitely improve. So there's too many meds that you're not going to know them all overnight, but it will be something you get better at. Yeah, so like exactly, like if they're taking Lasix, they should be on potassium. If they're on Lasix and they're not on potassium, I'm like, why aren't they on potassium? Why aren't they? So definitely. And I can kind of wonder, like, what's up with their potassium? Do they have too high levels? Like I'm asking a lot of questions. Very good. Next one. Last one, I believe. How many times do you check a medication before administration? How many times? 3 times, 3 times, 3 times. Okay, you guys have been all waiting on that short answer one. Sweet, yes, we check it 3 times. Awesome job. Did I get them all? I think I got them all. This slide was a long slide. All right, I'm going to toggle over to my next one. So I'm going to go quickly through some of the content here from chapter 33. So IV meds is the most rapid. We hit that. Factors affecting it. So we talked about liver function and how it could lead to toxic levels of medication if that liver function was decreased. We talked about maintaining that minimum effective concentration level. If we give medications late, we might drop below that minimum effective concentration level. So we want to keep our patients there. Older adults, there's so much for older adults, but we talked about the big thing, changing positions slowly. We talked about meds, long-term anti-inflammatory meds for things like arthritis and how they put the patient at risk for GI bleeding and anemia. Another thing here is pill organizer. It's a simple tool, but a pill organizer could be very helpful to help our patients, our elderly population, take their medications. And we've also hit on those fluctuations in blood pressure and needing to instruct them to change positions slowly to accommodate for that blood pressure change. We also, thanks to Jasmine, remembered that chances are they aren't going to listen, but we always need to educate our patients regardless. All right, so we're going to go into chapter 34. So another pretty big one here. I'm going to toggle back to our screen so I can see you guys. So the first one here, review proper eye and ear medication administration independently. There's a couple questions here where it's going to say, how would you give this eye medication? How would you give this ear medication? I need you to look that up independently. Just a couple, but it's probably worth your time to spend a few minutes on that. For example, like the pinna, that outside of the ear, it needs to be pulled up and back when giving medications for the ear. That's the type of thing that could be useful. So spend a few minutes reviewing the administration of that independently. The next one, if we assess a patient has difficulty swallowing pills, what should we do? So we've determined they can't swallow pills. What should we do? So yeah, so we need to consider a different route. We need to consider crushing or giving the patient liquid. Now, if we crush medications, what should we mix it with? So applesauce, if we crush something, we give it in something thicker like applesauce. So we could crush the medications. Now, what if this was a long-term thing? Like, okay, this patient just cannot swallow, nothing's changing. They're not going to be swallowing, I don't think, anytime soon. Would we want to crush meds for the rest of this person's life? If you're just like, I'm going to crush forever. No, we'd want to switch the medications to liquid, right? So if it's short term, totally, I'm with you. We could crush the medications for a day or two or three, if it's a short term change in this patient. If it's a long-term thing and they're going to be having this difficulty swallowing for an extended period of time, we want to change the order to liquid medications because it's going to be closer to the patient's dose. It's going to be easier to give them. Now, if no liquid's available and we can't crush it, and say we need to try for this patient that has maybe a mild difficulty swallowing, how would we instruct them to hold their head and their chin when swallowing? Now, of course, I'm not going to give this to somebody who really can't do it. I'm not going to say, okay, you've got to do it. This is a patient with just a mild difficulty. So if they just had a mild difficulty, I would have them tilt their chin down slightly to swallow. So chin down, I have patients that I have to say chin down, chin down, chin down, swallow, 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 swallow. Okay, so tilt their chin down slightly and swallow. Now, it shouldn't be all the way closed. If they tilt their chin all the way down, then they cannot swallow at all. So they need to tilt their chin down slightly and swallow. Now, of course, I would not do this for all patients. This is just a patient that has a little difficulty swallowing who maybe doesn't have an alternative route that we can give medications to, and you're still confident that they're able to do it. They just need some guidance. So that is how we would guide them. How do we instruct a patient to use a MDI or a metered dose inhaler with a spacer? So this was on one of your tests recently. So how do we instruct them? I know it's a kind of a longer answer, but maybe if you just throw out one or two, love Crete, right? As I'm like, you don't have to give the whole answer, love Cretes. Nailed it. Way to go, girl. So if you want to type some general thoughts in there, you can throw them in there as well. So the patient should sit up or even stand, but they need to make sure that they're opening their airways. So they need to be in an upright position. They shake the canister to mix the medication. They place the mouthpiece of the chamber in their mouth between their teeth. Make sure that they have a seal around it. They completely exhale from the nose, depress the canister, and breathe in slowly and hold the breath for 10 seconds, trying not to cough. So that is the official way. You can review that in the book. I know that recently you guys all experienced a very similar question. You will notice that many questions in the final exam are going to be similar to questions you've taken before. I don't have a percentage, but it seemed like deja vu whenever I went through your final exam. Not every single thing, but a lot are going to be similar. This MDI or metered dose inhaler is kind of similar to that, where you're like, hey, I think we just did something like this. So do review this. How do we administer a rectal suppository? Sims position, right or left, Jasmine? Kevin, you're fast. Ooh, controversy. Right, left, right, left. So we want to place the patient in left Sims position. Left Sims position. And do we go through the feces or around the feces? Sorry, Jasmine. We go around it. We don't go through it. If you go through it, it's not going to be as effective. You go around the feces. So you place them in left Sims and you go around the feces rather than through. Very good. How do we administer medication through a transdermal patch? So you're going to put a patch on them. Some of these questions you put earlier in the chat box when it came to patches and things. So transdermal patch, they should be placed in areas with good circulation, like the chest, shoulders, or upper arms. They should avoid hair areas with a lot of hair, so you should go to a hairless area. And what do we write on the patch? Date. What else? Time. Ooh, and initials. Okay, between all of you, we've got it. We write on there date, time, and initials. Now, do we want to always pick the same patch? You move it from the right shoulder, put it on the right shoulder. Remove it from the right shoulder, put it on the right shoulder. Do we always pick the right shoulder? Rotate. Why do we rotate? Just because we like to spice it up? Keep it spicy. Negative, right? So effectiveness, we want to make sure we're allowing it to absorb well. We also want to prevent irritation. Like, you guys can't see me, but I'm a very skin irritated person. Like, if you put the same thing on the same part of my skin over and over and over and over again, it would not work well for my skin because my skin is susceptible to irritation. So we want to rotate the site to prevent irritation as well. Now, some of you have rock solid skin. You could put something there over and over and over again, and you'd always be fine. But think about our geriatric population. And some of our patients just have sensitive skin. So we also need to rotate that site to prevent irritation. Now, do you want to make sure, how do you keep this medication from getting on your skin? So you're going to put a patch on it and the medication's on the patch. You don't want to get any on your skin. Can you prevent it from getting on your skin? Gloves. Sounds simple. Sounds simple. It ain't so simple. Make sure you're wearing gloves. Because if you put some of that medication on a patch and you get some of it and it absorbs into your skin, you're going to get a little bit of what the patient's getting. So you need to be very careful. Wear gloves and treat these medications very carefully. Very good. So, yeah, you never cut the patch. You never cut the patch. Very good. So the last one, how do we administer medications via feeding tube? We've talked about this one. We crush them all up, make it a little medication cocktail for the patient. Let's go for it. Don't mix, give them individually. We flush the tubing in between medications. Do we make sure that the feeding tube, the feeding solution hits the medication, so the feeding just stopped and then you immediately put the medication in after it? So no, we want to make sure that the feeding doesn't mix with the medication. So We want to always, if they were recently receiving tube feeding and you had to stop the feeding to give them medications, that you flush that tubing. Usually it's with 15 to 30 mLs of water, and then you add the medication, and then you'll do one medication at a time, flushing in between. We've talked about it. It seems like a lot of fluid. It depends on the patient. It depends on how often. All of these things we have to keep an eye on. Yes, we always want to also check for residuals and make sure that our patient is able to fully digest what they're getting. So usually before initiating the feeding or changing the feeding, or we want to check for residuals. And make sure they're sitting up. Remember, would you have a patient swallow their pills if they're laying flat? Like you're like, hey, let's give this a shot. Lay flat and let's see what, no. So same thing with feeding tubes. Just because it has a feeding tube doesn't mean that you don't need to sit them up to eat and drink. So you need to make sure that their head of the bed is elevated when they're having their medications, when they're having their feeding tubes, to prevent aspiration. Very good side note, Miss Jasmine, very good. All right, we're gonna quickly run through these concepts on the slide. So I told you to go over eye and ear medications independently, spend a few minutes on that. Here you see that pinna being pulled up and back for these ear medications. Suppository, we said we go around. Jasmine said ew, but we do go around and not through. So we see that suppository position here. Remember, they would be in a left Sims position when we administered this. The next one, chapter 30. Oh, sorry, this is a repeat. So topical, we talked about transdermal medications and where to apply them. Some of these same answers you see here. Very good job, guys. Meds via feeding tube, if patient can't swallow. Meds in liquid form are best. Tablets can be used in place, but we don't ever want to mix those meds with the tube feeding. So we always want to flush after that feeding and then start administering meds one at a time. Now we're going to go into chapter 35. I'm trying to hustle to get there, guys. So another big chapter here. I'm going to go over to the chat box. So chapter 35, the first one, how to administer a TB skin test. So is it IM? Is it IV? Is it, so it's ID, intradermal. We need to inject slowly to be sure that a bleb forms. So it's an ID injection. We need to inject slowly to be sure that a bleb forms. The bleb is very important. When do we read the test? 15-degree angles. I love it, Elizabeth and Josefina. When do we read the test? So what's the time frame? 48 to 72 hours, 2 to 3 days. They cannot come in at 46 hours. They cannot come in at 78 hours. It is 2 to 3 days, 48 to 72 hours, period. So if they tell you when the test was administered, you need to be able to look at the window and decide when they would need to return. This is the biggest part about giving a TB test, is the education on when to return, because patients are not compliant. They don't return. So make sure that you instruct them on this window. Very good. Subcutaneous injection, what is the angle? So this one is another angle range. So what is the range? 45 to 90. Now, how do I know to pick 45 or 90? Just like, I don't know, 45 seems good. How big the patient is, right? If you feel like if you go at a 90 degree, you're going to poke through to their stomach because they're very, very skinny, then don't go 90 degrees, okay? I find that most of our population can handle a 90-degree angle, and that's what I'm comfortable with. But if the person is larger, you're going to need perhaps a larger, longer needle, and you're also going to need to change your angle. So the angle we select depends on the size of our patient. Now, if we give an injection, say we're gonna, it's all right, Jasmine. We know that you're rushing to type. You're doing great. Do we recap a needle? Say I go into the room and I've given them a subcutaneous injection of something. We never recap after. So if the needle has a safety device, we lock the safety device immediately. Not all needles have safety devices. If it has a safety device, we immediately lock that safety device. Awesome. It is safe, and we still dispose of it in the sharps. If it does not have a safety device, what we need to do is walk it immediately to the sharps. You don't lay it on the bedside table. You don't put it in the bed. You don't do weird things with it. You take it directly to the sharps container. Very good. Now, for somebody who's getting subcutaneous injections of, say, insulin, they're going to be having insulin all the time. Much like the patch that we talked about rotating, we want to make sure for our patients that are on continuous subcutaneous injections is that we rotate those sites to reduce tissue irritation, just like we previously talked about. So you guys did really good in previous discussions. So we want to make sure that we rotate sites to decrease tissue irritation. The next one is, how do we safely use medication from an ampule? Filter needle. Wrap gauze around the neck and break away from yourself. Very good. So you can use a gauze or an alcohol pad. To me, gauze is safest, but it really depends on what you have available. Filter needle, and you can't give it with a filter needle. A filter needle will look like a little flexible tube. So you would know like that you cannot know. So definitely you'll want to switch to a regular needle. You're going to filter it. Now, would we want to inject air into an ampule bottle? So you just pop the top on the ampule, you flicked it, you made sure all the medication was down, and then you've done all of this. You've put your life in danger to pull medication from this ampule, and then you inject a whole bunch of air in it, and then it bubbles all over the side. Like, there's no more med. That's what will happen if you inject air into this ampule, is you have spent all of that time and energy, and all of it will bubble out the sides. So be careful that you're wrapping that neck around, you're breaking away from yourself. If you need, you can even tap the top to make sure that the medicine goes in the bottom. You're going to use a filter needle. That's going to filter out any glass that might have gotten into the medication. And then you're going to draw up your medication, making sure to not instill air. And then you're going to switch to that regular needle to administer the medication. Very good job. All right, then next one, how do we mix insulin? So the first thing we're going to do is we're going to put air into the cloudy. Then we're going to put air into the clear. We're going to stay in the clear, draw the clear dose back. Then we're going to move over to the cloudy and draw back the cloudy dose. So I'll repeat that one more time. We're going to put air into the cloudy. We're going to move over to the clear. We're going to put air into the clear. Then we're going to draw back while we're still in that same vial, that desired dose of the clear insulin. Then we're going to move our needle over to the cloudy. We don't need to inject any air because we already did that, and we're going to pull back on the cloudy dose. So the first thing we're going to do is air into the cloudy, and we're going to finish by pulling out from the cloudy. So do know that sequence of events for that. And IM medication in an adult in the ventrogluteal site. So the two main landmarks is the head of the trochanter and the anterior iliac spine. So I do have a slide on that. I'm not going to go into it in great detail because of the essence of time. We're running a little bit behind. So the two main sites are the head of the trochanter. I'll try to show you briefly in the picture, and the anterior iliac spine. Those are the two main anatomical spots. And how do we select the needle length and gauge? How do we select let's start with needle length. So we talked about it for subcutaneous, right? The size of our patient. If we're giving IM and the patient's large, they're going to need a longer needle. If we're giving an IM and the patient's smaller, they're going to need a shorter needle. It depends on where you're trying to hit. If you're trying to hit subcutaneous and your patient's larger, you might need a longer needle. So remember, length of the needle depends on the size of my patient and also what route am I trying to hit, what route am I trying to administer. If you pick a very long needle and you're giving subcutaneous, chances are you're going to go much deeper than subcutaneous. So that would be bad. So do always match your route and your patient to what length of needle you need to pick. Now the gauge of the needle is the width, or how wide, how thick that needle is. Make sure when it comes to the gauge, do you want the thickest needle that you can use, or do you want the thinnest needle that you can use? So when it comes to gauges, do you want the thickest needle? So you're like, I'll pick the thickest needle I need. Or do you want the thinnest needle to get the job done? I don't know if I lost you guys or you. Oh, there you go. Okay. So we want the thinnest. We want the thinnest. So if we need the thick needle, use the thick needle 100%. If you need it, you need it. But if you don't need the thickest needle, you don't say, I'm going to use the thickest one just because. So you always use the gauge that's needed to get the job done. If you're giving something like testosterone that is very, very thick, and you need a very thick gauge needle, which is going to be a lower number, like an 18 gauge, that's a very thick needle. I might need an 18 gauge or a 20 gauge to give something like testosterone. But if I'm giving something like a flu shot that's very, very thin, I'm not going to make the patient take an 18 gauge needle just because. So we use the gauge needed for the medication I'm going to give and the patient, but we only use the smallest needle needed to get the job done. But if it requires a thick needle, you're going to use the thick one, okay, guys? So you always pick the smallest or the smallest diameter needed to get the job done. All right, so I'm going to toggle back over. We're going to hit our next section of slides. So here we talked TB test. We talked that 15-degree angle, and that small bleb is needed. So we need that to inject slowly for that bleb. Here we have subcutaneous. We talked about rotating sites. We talked about that 45 to 90-degree angle depending on the amount of subcutaneous tissue that patient has. Ampules, we went over this in detail, different things that we could do to keep ourselves safe when dealing with an ampule. Mixing of insulins, we talked about how the first one was injecting air into that cloudy and then all the different steps. You can review this figure in your book to go through that again. Next, here we talked about those two landmark sites, which was the greater trochanter and the anterior iliac spine. So here you see the nurse putting her palm over that greater trochanter, and then you see her going for that anterior iliac spine with her index finger. So those are the two main markers that she's feeling for when preparing to give a ventrogluteal IM injection. And then a little bit of information here on needle gauge and length. Remember, these are all flashbacks. We've done these before. You can always use this presentation to go back to your notes if you need a little bit more on it. And now we're going to jump into chapter 37. So chapter 37, the first question, what are some considerations for the older adult when it comes to surgery? So what are some things that we need to consider when it comes to the older adult and surgery? So the older adult and surgery, are they going to need the same amount of anesthesia perhaps? Are they going to need more or less potentially? Perhaps less. So you need to make sure that you always have an updated height and weight because they might need to adjust the amount of anesthesia that this patient gets. The other thing, hydration. Hydrations always come up with the elderly. The extreme old and the extreme young are at risk for hydration issues. So we need to make sure that their height and weight's available, and we need to make sure that we're being proactive when it comes to hydration and et cetera for these patients. Very good. And Jasmine, also good thought on they're not going to heal the same. So post-operatively, definitely some things to focus on as well. The next one, who identifies the surgical site prior to surgery? So the patient does. So the patient says, it's this leg. We don't wait till the patient's unconscious and we go, oh, okay, it's the right, and the patient's sedated and they don't have a chance to say that it is not. So to help prevent errors in surgical procedure, that the patient must be conscious so that they can participate in the marking. Now, generally the patient doesn't actually take the marker and do it, but they will point and interact. The key point is that they are not unconscious, that they remain conscious when the surgical site is marked. So they need to be conscious during the marking. Although they might not be the one marking, they need to be involved in the process. Discuss some preoperative teachings that should be given to the surgical patient. So before they even have surgery, what type of things should we be teaching them? They haven't even went into the operating room and we've already taught them all this stuff. What type of things should we have already taught them? Possibly about diet, right? They might need increased protein for surgical healing. That's a great thought. What other type of things? Breathing, right? Sounds basic. Turn, cough, deep breathe. Turning, coughing, and deep breathing. Pain control, that the need for pain medication might exist. definitely. Incentive spirometer, we went over that. Perhaps their home setting, maybe how, Valerie, you're probably talking about like removing rugs and doing, oh, perfect. Yep, I'm with you, girl. So different things that they can do to keep their home safe for after surgery, totally. Incentive spirometer, I think I mentioned that. Now, one thing that I want to touch on real quick is turn, cough, and deep breathe is a great thing. I always stress the importance of the basic things. But I do want to point out that coughing might be contraindicated for some patients. So not every patient is instructed to cough. Some patients are told, you better not cough because it could be contraindicated. These type of patients could be like a brain surgery patient. They might not want them coughing. So they might not want them actively coughing right after a brain surgery. The other one might be a hernia repair, a very fresh hernia repair. So I always stress the importance of turn, cough, and deep breathe. But I do want to add that coughing sometimes, for some people, could cause an increased pressure. So an example of that would be brain surgery or hernia repair. And for these patients, we might want to be careful to not instruct them to turn, cough, and deep breathe. Now, incentive spirometer, that device is good for respiratory health for just about every single patient. So for somebody who had brain surgery or hernia, they might be pushing them to do the incentive spirometer rather than turn, cough, deep breathe. Does that make sense? So I'm adding a little bit of additional information that I don't think we've hit before. So I want to make sure that that makes sense. It looks like, Valerie, you're with me. I don't see anybody against me, so I think we're cool. How does getting up and walking help the post-surgical patient? Like up and walking, how does that help them? Post-op complications like pneumonia, blood clots, and constipation, helps to get their oxygen and blood flowing, awesome things. Blood flowing, oxygen's moving with blood, so that's good. Helps prevent constipation, all great things. So I'm going to focus on gas. So a lot of times after surgery, patients say, I have so much gas. The big thing we need to say is, you need to get up and walk. You need to get up and walk. So especially for our patients that complain specifically of gas pains, we need to promote them early walking, because walking does all of these things, but especially for our gas patients, they need to walk to try to work some of that stuff out. So early ambulation is key for them. The next one, what are things we must check before giving patients liquids? So we've hit on this. So we need to check their doctor's order. Always check their airway, their order, and their gag reflex. The other thing is, we've hit on all of these. So you've checked their gag reflex, you've checked their order, you know what they can have, their airway looks good. What else? So you're like, in your mind, you're like, I'm gonna go get that water. I'm gonna hook my patient up, I'm gonna get that water. What do I need to check maybe first? So once the water goes in, where's it gonna go? It's gonna go down to the stomach, right? And then it's gonna go through the GI system. And say we follow that water up with Jello, right? Clear liquid. Then we say we follow that Jello up with pudding. And you're like, they're doing so good. They're swallowing. They're so smart. Look at them go. Exactly. Are their bowels moving? So if we put something into a machine that's not fully functioning, it's going to be stuck there. Okay? It's going to be stuck there. So think of your patient. Okay, sure, they can swallow. They got the order. Everything looks good. You checked. You're like, okay, I'm going to get that water. But you haven't checked their bowel sounds. What's going to happen? Now, water, sure, they'll make it through the water more than likely. But what happens when they say, okay, I sip the water, see, I'm good. You hand them a sandwich, they eat the sandwich, and their bowels have never started working. That sandwich is not going to go anywhere, okay? So we also need to check the bowel sounds. So we need to check bowel sounds. So we are including, we check the airway, we check the order, we check their gag reflex, but we also need to check their bowel sounds. Now, when it comes to just water, definitely, we still check the bowel sounds before even giving water. But for some people, they're like, why? It's just water. But if you think about after water, we're going to escalate to new things, then it might help you make sense why we check the bowel sounds prior to giving anything by mouth, because we want to make sure those are working before we're starting to give our patient anything by mouth. So we're adding that extra last kind of segment there to our thought process that we've talked about before. Okay, so after surgery, we're going to check those bowel sounds and add it to those list of other things that we're checking. So I'm going to cruise over. We're going to go through chapter 37. So general anesthesia. We talked a little bit about that. There's some special concerns for older adults on page 736. You can review that as well. We talked about how the patient needs to participate. They need to be conscious when we go ahead and mark that surgical site. Pre-operative procedures, we're going to teach things like coughing, deep breathing, turning. We can even teach them leg exercises, pain control, lots of different things. Remember, we also illuminated on the fact that that coughing and deep breathing might not be indicated for every patient. So we need to also be cognizant of what type of patient we're teaching these things depending on the procedure that they have. The next thing, fluid and electrolytes. So we need to monitor bowel sounds. We talked about bowel sounds and making sure that their sounds are working before giving them food or water. And now we're going into chapter 38. So we are just about there. It's probably going to be 10 or 15 more minutes, but I'm going to hang in there with you guys to the bitter end. We're going to do this. I'm going to take a quick sip of water, though, because I'm starting to die over here. So chapter 38, explained wound healing using first, second, and third intention. So just taking a sip of water. If you want to chat there, first intention, second intention, third intention. Go ahead, guys, take just a second and I'll be sure to cover. Okay, so let me go through this. This wasn't one of my lectures, so I want to make sure I cover it real quick. So first intention is when the wound has little tissue lost. Okay, so the wound edges should be approximated. When we say that the edges of a wound are approximated, it means they come together, okay? So those edges are together. Now, this first intention are things like surgical wounds. They're very clean. These are pretty wounds, meaning they are together. They are, for the most part, closed. Very little loss. They're pretty, okay? Now, the next type is second intention. These are more rigid, not so pretty wounds, meaning there can be gaps in it. So these are severe lacerations, things that are more rigid, meaning that their edges have not come together, okay? So these edges do not approximate and the wound is left open, okay? So that open area, either because it was a nasty laceration or a surgery that went very wrong and it was very open, these wounds are left still open, and these areas are going to fill with scar tissue. Now, the third approximation, this is secondary closure. It's called either delayed or secondary closure. So an example of this is a wound that's left open and closes later. So secondary closure means it's not closed initially, it's closed later or secondary. So this third, this is secondary closure. So it means like if they had, let's say, a big abdominal wound. So it was left open because it needed to drain. And later on, after they drained properly or something occurred, then they were going to close it. So first, that's a clean, pretty wound. The edges are together. It's like a clean surgical wound or a small laceration. Second is that more rigid. It's a severe laceration, something that the edges don't come together. And third, this is that where they leave it open now and they can go see it later and then fill it in or close it. So later on, they leave it open, and later on, secondary, they come in and close it. So do make sure that you review first intention, second intention, and third intention. Okay, guys? So spend a few minutes on that. Now, what are some factors that affect wound healing? Living conditions, totally, yeah. Age of patient, definitely. Diet, their nutrition level, poor nutrition, poor healing. Older age, slower healing. Living conditions, perhaps even less socioeconomic resources can affect diet, things like vitamin C, how much protein they get. Protein, remember, is for tissue growth and repair. A diet low in protein may be affected by amount of income that could affect a patient's healing. very good. All things. What about smoking? Smoking. Smoking, we all know, is bad. Smoking is going to reduce the amount of oxygen that goes to that area that's trying to heal. So smoking is going to further reduce healing times. That's another special consideration. So all of these different things are factors that affect wound healing. The next, explain the inflammation phase of wound healing. Oh yeah, it's a real quick. Yeah, if they're diabetic, so I think about it like this. This is very, in my mind, easy to understand. So if you have a wound and you have a lot of sugar in your blood, the wound likes that. It makes the wound grow and continue to expand. So diabetics have a very hard time healing because they're essentially feeding that wound. And that's why diabetics, something very small, like a very small little prick, can end up being a very big thing. They can't feel it. They have very high sugar content. And so diabetics have very special healing that we need to monitor very closely. So diabetics, definitely. So I'm going to move into inflammation. So inflammation, when does it begin? Inflammation, when does it begin? Hang with me, guys. When does inflammation begin? So inflammation begins immediately after, oh, nice, Itzel, immediately after injury, and it lasts approximately 3 to 4 days. So it's inflammation is a localized, so it's in a specific area. It's protective response. It's brought on the body because of injury or a destruction of tissue. So you're going to have an injury, some sort of tissue destruction, and in efforts for your body to protect itself, it's going to inflame. That's going to happen pretty much immediately and last 3 to 4 days. So that's inflammation. The next one. Now let's spend a minute here. What do you expect if your patient is hemorrhaging? So they're losing blood. Remember, we talked blood pressure. Blood pressure is mainly composed of volume. When you have too much volume, your blood pressure goes up. When you have too little volume, your blood pressure goes down. Now, as your blood pressure goes down, your pulse goes up because you don't have enough volume. So your body says, oh my goodness, I don't have enough volume. So your heart goes pump, 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 pump to try to move the volume you have around so it can perfuse your tissues. So low volume, your heart compensates by pumping very fast to try to pump around to all of its necessary organs. Very good. So definitely some findings include decreased blood pressure. And with that, we're going to have that increased pulse rate. We're going to have the respirations also go up. Your patients are probably going to be diaphoretic. They're going to be cool. They're going to be clammy. And for these patients that experience a lot of blood loss, hemorrhage, they're at risk for hypovolemic shock. So hypovolemic, low levels of volume. You think about them bleeding. They're losing a lot of fluid. They're at risk for hypovolemic shock. We're going to expect these findings like decreased blood pressure, increased pulse rate, etc. They're going to be cool. They're going to be clammy. We're seeing good words like shock, low blood pressure, increased pulse, and increased respirations. All very good thoughts, guys. The next one, what is TELFA and why would it be used? So let's focus on TELFA first. What is TELFA? TELFA. Non-adherent dressing, awesome. So TELFA is an example of non-adherent dressing, very good, KB. So TELFA is an example of a non-adherent dressing. Now the way these non-adherent dressing, they literally don't adhere. So they're non-adherent, meaning they don't stick. So they're non-adherent. How these work is there's a shiny side that does not stick. That shiny side is non-adherent. It will not stick to your patient. So what they do is they apply that to the wound. Now all the junk from the wound, like the exudate, it seeps through and collects in the absorbent material on the other side. So it's going to go through that shiny side that's not going to stick to them, and it's going to absorb through to the other side. So TELFA is a type of non-adherent dressing. This dressing is particularly useful when you pull off the dressing, and if everything comes with it and you're having to pry it off your patient, then you are using the wrong dressing. Chances are they needed non-adherent dressing because you're doing more damage when you remove it every single time. So this non-adherent, it's an advantage to reduce trauma to that wound. And also the non-adherent dressing is good because it's going to absorb that exudate and bring it through to the other side, the non-shiny, the non-adherent side. So Telfa is an example of a non-adherent dressing. Very good, guys. Now, Montgomery straps. Montgomery straps. I had to really work hard to find this in the book. So Montgomery straps. Is that familiar? Yeah, awesome. So I have some good thoughts there on Montgomery straps. So Montgomery straps, these are basically tie straps. So these straps allow for changing the dressing without using a whole bunch of tape. So it holds the dressing it's protecting the patient's skin from removing that tape over and over and over again. So this would be particularly useful for somebody with very sensitive skin when we're messing with their skin every time removing that tape and removing that tape. So Montgomery straps, very good. And how do we remove tape? So say we can't use a Montgomery strap, how would we remove the tape? Do we move it away from the wound, towards the wound? Do we remove one side at a time, towards the wound? So we want to gently loosen the tape ends, and we're going to move it towards the wound while we're applying some light pressure, basically to keep the skin nice and taut. So we want to move it towards the wound, Okay, everybody? Very good. The last one is you're going to independently review the steps to performing an eye irrigation, as well as how to empty a Jackson Pratt. So there's just a few questions on this, but I would look up eye irrigation in this chapter, and I would also spend a few minutes on how you would empty a Jackson Pratt, or what we call a JT drain. So that's going to be an independent assignment for you guys. If you guys want to score those points, I would spend a few minutes there. All right, we are almost there, wonderful people. We're going to flip through this real quick. So first intention, second intention, third. So we went through this briefly. You can refer back to here, chapter 38, if you want. Here we went over some factors affecting wound healing. There are several. We talked about some of them briefly. Inflammation process. Remember, it's immediately up to 4 days. It's your body's natural reaction to some sort of impact or tissue change. Wound complications, including hemorrhage. Think about it. Fluid comprises your blood pressure. Lack of fluid, we're going to have these decreased blood pressure and that increased pulse rate, as well as increased respirations. Your patient's going to be restless, diaphoretic, cold, and clammy. Remember, hypovolemic shock may occur. This is when their volume levels go too low and they actually become in shock. So hypovolemic shock can occur. Securing dressings, we talked briefly about Montgomery straps. We also mentioned non-adherent dressings. I'd spend a few minutes there. And now we're going to go into chapter 39. So explain the basics of traction. So traction, in my opinion, it's a little tricky. So there's so much about traction. So I'm going to hit just a few very basic points. So traction can be a little tricky. I mean, because it's something that we do see, but we don't see a ton. So let me try to make it as basic as I can. So traction is basically where you put a pulling force and weights to maintain a part of the body in some sort of specific alignment or position. So it's a use of a pulley system and weights to keep your body in a specific position. That's what traction is. So it's used to realign bone ends. So the part of the hospital where we're going to see this is the ortho floor. I was never a huge ortho nurse. I don't think traction is used very often, but they can use traction to realign bones by using a system of pulleys and weights to keep bones in very specific positions. There's a couple different kinds. There's manual, skin, and skeletal traction. Now, I'm not going to go into these specifically, but basically the doctor will give you an amount of weight and how long patient should be in traction. But the big things that I want to point out about traction is that the weight should not swing freely without touching the bed or the floor. So the weight should not be like just dangling around. Another important thing is the patient's feet should not rest against the foot of the bed because that's going to interact the traction. So if your patient's feet are pressed against their bed and they're in a pulley device meant to keep them in a specific position, then their feet resting there on the bed, that's going to interrupt that counter traction. Another thing is we want to make sure the ropes aren't tangled, because if the ropes aren't tangled, then they're going to be at risk for not having that pulley system work well. Another thing is your patient should be centered in bed. So I know traction is a little bit of there's not a ton on traction. Some of these more key points can be tested on, like making sure the weights, I said that wrong, the first part. The weight should swing freely without touching the bed or floor. I said with, I meant without. So the weight should swing freely. They shouldn't be resting on the bed or floor, and the patient's feet should not be resting on the foot of the bed because we don't want to affect that counter traction. I am going to put in a table in there because I have it in my notes because I thought that this would be a little bit one of question. Table 39.2, I have it on page 793. There's not a ton on traction, but I would say it's worth a few minutes for you guys to review in chapter 39. So think of it as the system of weights and pulleys meant to realign a bone. The doctor will set how much that you need to give. Remember, those weights should swing freely without touching the bed or floor, and the patient's feet should not be resting on the foot of the bed because that's going to counteract that traction that's needed. We want to check the ropes and the pulleys and make sure there's no tangles and make sure our patient's nice and centered in bed. It's going to be some of those main concepts, but you can refer to table 39.2 if you need some more information there. All right, what do you expect to see when a cast is removed? So what's that leg or arm going to look like when you take that cast off? Is it going to be like shiny, brand new, like baby skin? Dry and scaly, atrophied, very good. So the skin underneath the cast is going to be dry. Is it going to be super clean? Like you're like, oh, shiny. It's going to be clean or it's going to be very dirty? So the skin underneath is going to be dry and dirty in appearance, and it's going to be foul smelling, okay? It's not been washed, it's been stuck, it's been stuck in its own odor. So expect things like dry and dirty and foul odor, and expect it to be atrophied. These are all very good thoughts, guys. Washing with soapy water and rinsing and applying lotion, this will help remove that dead skin. So essentially there's lots of dead skin that have developed there as that cast has been in place. So we want to instruct our patient, make sure to wash, rinse, apply lotion, and this will all help remove some of that dead skin that has accumulated underneath that cast. Very good. The next one, how do we assess the extremity a cast is on? So say I have a cast on my left leg, how do I assess that left leg? What are things that I assess for? So even if I have a cast on the left leg, I can look for circulation and color and pulse. These are all good thoughts. So I can see some skin, right? If you can see the left foot, if my foot is pale or blue, that's bad. So Jasmine, are you capillary refill? I'm guessing, Jasmine. Where you press. Oh, yes. Okay. Thank you. That was a fun guessing game. So yes, you can assess things. You can assess their skin. You can assess their sensation. Even touching a patient saying, can you feel this? You can assess their sensation. You can assess their pulses. You can assess their capillary refill and their pain. So these are all parts of a neurovascular assessment. Ooh.
Instructing a patient to alleviate swelling after cast is applied.
Say that again, dear.
How do we instruct a patient to alleviate swelling after the cast is applied?
Oh, thank you, Valerie. Thank you. They have a cast. What do we tell them to do with that casted leg? Elevate, right? You elevate. How far should they elevate? Like, I've seen some people elevate literally like 2 inches. I'm like, don't waste your breath. Trust me, it ain't worth your time. What level should we elevate them to? 1 to 2 pillows is a great answer, but we're looking to elevate to the level of the heart. Okay, perfect, KB. Thank you. Thank you, Valerie, for keeping me on track, girl. So we want them to elevate to the heart level. We want them to elevate on 1 to 2 pillows as much needed to get them to that heart level. So proper elevation is what's going to be a major instruction for when that cast is on. Let me make sure. Okay, I think I'm good. Oh, I see it now. And then we covered neurovascular assessment next. Now, neurovascular assessment that I covered is in box 39.3. I'm going to type it out really quick. So this is where we were talking about checking the pulse and capillary refill and things like that. Now, the last one here is, what is CPM? What is CPM? Continuous passive motion machine. Perfect, KB, awesome. Continuous passive motion machine. Now, what type of patients are we going to use the CPM on? So, like for extremities? Yeah. Now, totally. The big thing we're going to see a CPM machine on, the biggest thing we're going to see a CPM machine on is your knee replacement patients. So now, for our patients that are not conscious on bed rest, you're going to see the sequential device, the one that they hang from the foot of the bed and they put on, and it inflates with air, deflates, and it creates that on and off pressure. So for that, we're going to see a sequential device. Now for the CPM, this continuous passive motion machine, we're going to see this big time in our knee replacement patients. So what happens is, so the boot-looking things, the things that strap up their legs and go on and off, on and off, on and off, those things. Let me ask Jasmine real quick. We're just about, so those ones are sequential devices. Now the ones that inflate with air, and you hear them like pump up, and then you hear them like pump down, and you hear them pump up. Those sequential devices are big for patients who aren't moving in bed. It reminds their heart to pump blood down to their feet when they're not moving much. They're on bed rest, etc. Now the CPM works a little bit different. So the CPM essentially just moves their knee joint back and forth. So they lay down and they put their leg in this machine, and what it does is it pushes the leg out and pulls the knee up and pushes the leg out and pulls the knee up and pushes the leg. It does this over and over again. Now the reason we wouldn't want to use this for a bed rest patient is because it's just basically working out the knee over and over and over and over again. Yes, it's going to promote blood flow and other things, but the CPM is big time for our knee replacement patients. Because it keeps their joint moving. Because with a knee replacement, if they don't move, they can actually have their joint become frozen and stiff, and they have to go in and do an additional procedure where they pull their knee very, very hard to re-loosen up all of the tissue there. So what we don't want their knee to do is lock up. So we use something like a CPM to move their knee back and forth, back and forth, back and forth. And at first it's just a little bit, and then it's more, and then it's more. More meaning a more stiff angle. So the angle becomes more increased and more increased. And it's so that their knee joint doesn't become stiff or locked in position, requiring an additional surgery. And that surgery I've seen, it's intense. They basically just pull it really hard and it breaks up all that tissue, and the patient starts back from square one. So that CPM machine, this is big time for our knee replacement patients. It's basically going to extend and flex that extremity, that knee, and it's going to be using angles over a specific period of time to make sure that the joint stays nice and loose. Okay, so I'm going to flip through these real quick. So traction, weight is, and I'm sorry I said this wrong just because my brain's getting tired. The weight should hang freely, but the patient's feet should not rest upon the bed because it will ruin that counter traction. So I'm sorry I misspoke on that one. The cast, we talked about what the skin would look like. Underneath that cast, how we can educate the patient to get that dead skin off. We also talked about elevating that extremity on several pillows to keep it at heart level. And then the continuous passive motion machine. This is often to restore joint function after orthopedic surgery. Now, we don't use this for our hip plate patients because they can move their own knees. It's mainly seen with the knee replacement patients. Let me see if I have, and here it is right here. So Jasmine, what you were talking about is that little white cord that goes up to those white leggings. Those white leggings, those are sequential devices. So this patient has their left knee in a CPM machine. That CPM machine's moving the leg down, moving the leg up, moving the leg down. So it's the one making sure that that knee does not lock. And even in this picture, you can see that this patient has a dressing. They totally are post-knee replacement. So they also have their sequential stockings, creating blood flow from that air inflating and deflating. And they even have a third thing underneath. They have a TED hose, which is basically just a compression stocking, also making sure that blood flow goes down to those feet. So this patient has three things for them. They've got their TED hose stockings, they've got their sequential device on, and they also have that left leg in a CPM machine, all trying to keep the blood pumping, preventing things like clots, and also keeping that left knee joint moving. So does that picture help? You guys probably don't see that anymore. Jasmine, did that help? Oh yeah, TED hose are the worst. But they're another thing, kind of like an incentive spirometer, where they are like so useful. But yes, they are very difficult. Did that picture help on the CPM, guys? Okay, so that makes sense. And luckily in it, we saw sequentials and TED stockings as well. So I know that this was longer than we expected, but hopefully that was very useful. So I know that it was a really long lecture, and hopefully this was helpful for you guys. I will, of course, be thinking of you guys on Thursday. Now, on Thursday, we're going to spend about 10 minutes together. I'll come, I'll say hello, this is what we're doing. Remember, the exam is 120 questions. It's set for 2 hours and 10 minutes, so you should have plenty. Make sure that you allow plenty of time to take your exam on Thursday. If you're somebody, there's been 1 or 2 students, maybe 3 students that have sometimes connection issues. So if you have connection issues, make sure that other users in the house are not on your internet when you need it. Make sure you log in with plenty of time to allow yourself your full 2 hours and 10 minutes if needed on Thursday. I will still meet with you guys as usual. I'll spend 10 minutes with you, and I will be with you for the very introduction. Of course, on Thursday, I will also be with you guys through the entirety of the testing period in case you guys need me on Thursday. Okay, guys? So tonight, please, you're not done for the night. I would spend the time to go over and listen to Melanie Guzman's live Cahoots. She also goes over some of that HESI information for you guys. So yeah, there were some people that had problems with a couple people. So do make sure as much as possible you keep your, yeah, it was Audrey and Jasmine. You guys blasted yourselves. So yes, you guys did have a hard time. So make it as user-friendly as you can to have your internet going on Thursday. All right, guys, so that's all I have for tonight. I'm gonna, if you guys have problems or you have questions tonight, I'm gonna go ahead and disconnect the call right now, or not like at this moment, but I usually stick around, but for recording purposes, I'm gonna disconnect here in another minute. If you have questions, just hit me up on Moodle tonight. I'll still be available to you guys, or send me an email. I'm still available to you, okay? I appreciate and thank all of you too. And I'll be thinking of you guys as you begin to study or continue studying for this exam. Thank you all. I will try to get this recording up for you guys as soon as I can get some assistance on that, okay? Thank you guys. Good luck studying.